welcome in. Before we get started, I'm just going to wait a little bit longer till we build up a critical mass. But in the meantime, I'm just going to go over some brief housekeeping before we get started. So this webinar is recorded. Um, so if you have a colleague that missed out today, we'll send out a video and the slides to the email that you registered with. And then we'll also upload this recording to our YouTube channel at the National Coalition for Homeless Veterans. So just search us up on the YouTube channel bar and then hit subscribe. All the past webinars and other content lives there as well. As usual, the chat is disabled. So if you do want to interact with our presenters, there's this tiny button that you'll see with a little question inside of a box, a question mark inside of a box. That'll be the channel that you use to ask questions. You can ask throughout the presentations, or you can wait to the latter half of this webinar for the Q&A portion to ask. But, me personally, I like to ask when I think about the question, but I'll leave that up to you guys. So it looks like folks, oh wow, we have quite a lot of people in here, so I'll just go ahead and get started. So good afternoon, everyone, and welcome to our webinar, Integrating Trauma-Informed Care into Your Program. My name is Jay, and I'm the Program Associate for the National Coalition for Homeless Veterans, it's our mission to end veteran homelessness. Now, this webinar kicks off our summer series focused on serving veterans in critical transitions. And we're really delighted to have you join us today for this very vital discussion about how to best serve veterans experiencing trauma. Now, before we get started, I just want to acknowledge the Home Depot Foundation for their generous support in sponsoring this webinar, as well as being impactful leaders in the mission to end homelessness amongst veterans. Now, many of you in this room have worked with many subpopulations of vets. Each veteran who walks through your doors can face a range of personal challenges that require us to shift the way we engage to best serve their needs. Things like housing, employment, healthcare are all really vital components of our work. But if we want those interventions to work, we need to understand how to engage and what can lie beneath the surface, and that's a veteran's trauma. So those who serve in the military may deal with adverse childhood experiences and other trauma, but also may be exposed to different traumatic events than civilians. A veteran may experience a traumatic event through war zone deployment, training accidents, military sexual trauma, all of which are common pathways to post-traumatic stress disorder. According to the National Center for PTSD, 7% of veterans will have PTSD, with women veterans being more particularly at risk. Many homeless veterans you engage with every day may have service-connected trauma, but also trauma that stems from other life experiences, including their battles with homelessness. Trauma can also impact how veterans interact with our nation's network of service providers. It can create distrust with the system of services and influence their decision to not seek out a provider. And as service providers, especially those in non-clinical settings, it's important to consider these different layers and ask the difficult question: how do I make my program as trauma-informed as possible? The purpose of today's webinar is to help answer that question. Our presentations and discussion will provide an overview of what it means to be trauma-informed, how to integrate those practices into our program, and how to engage homeless veterans who may be experiencing trauma. The presentations will offer insights through the lens of the VA and service providers to unpack various techniques and approaches to empower those veterans. Now, speaking on today's panel, we'll hear presentations from Jenny Hoggett and Dr. Catherine Messia. First, I'm going to introduce Jenny. Jenny is a licensed social worker and trauma consultant with extensive experience supporting communities impacted by trauma. She has worked as a therapist for children with developmental delays and trauma, as well as a trauma assessment specialist. She joined Easter Seals MORC in 2016, driven by her passion for helping others understand trauma's root impact on behavior. In 2022, she became a mental health consultant. Expanding her work through community and school-based trainings, she provides trauma support and trauma-informed care support to organizations navigating recovery. Thank you, Jenny, for joining us. And next is Dr. Catherine Messia. Dr. Messia is a licensed clinical psychologist and VA health systems researcher with extensive experience working with veterans who have experienced trauma and homelessness, both in VA and community settings. She completed her clinical internship at the New Orleans VA with a focus on trauma and PTSD assessment and treatment, and she completed a postdoctoral fellowship with the VA's National Center for PTSD. Additionally, she has experience working with service providers and homeless experienced veterans in VA's domiciliary, residential treatment, and mental health intensive case management programs, as well as community-based housing and employment programs. So we'll hear presentations from both of our speakers and again move into that Q&A. So if you do have questions in the middle of the presentation, feel free to use that question channel in the menu bar or hold on to them until the discussion portion at the latter half of the webinar. So I'll pass it over to Dr. Messia, who will kick us off. Thank you.
Thank you. I think, can we advance? Thank you. Hi, so I'm Catherine Messia, and I'm going to be speaking a little bit more towards integrating trauma-informed practices into systems of care for homeless veterans. Next slide. And as Jay actually did a great overview of just before we started, I was going to start out with talking a little bit about what trauma is and how it impacts veterans' health and service use. And then before going into information about what trauma-informed care is, with a specific focus on the service system or organizational trauma-informed care practices. And then end with like highlighting a promising practice that has been going on in the VA's homeless program office in terms of trauma-informed care for homeless veterans. Next slide. So many people will have different definitions of what trauma is. This is not the exact definition that, as trained as a clinical psychologist, that the diagnostic manual would say, but I also do not think the diagnostic manual is perfect. And SAMHSA provides a very good general description that trauma results from an event, series of events, or set of circumstances that are experienced by an individual as physically or emotionally harmful or threatening. And those then have lasting adverse effects on the individual's functioning, as well as physical, social, emotional, and spiritual well-being. And I think that's important to remember, because it's not just about the mental health symptoms. It impacts a lot of areas of their lives. And so I just wanted to ask everyone to think about some examples of types of trauma that maybe you've heard from homeless veterans that they've experienced, or things that come to mind with that. I think one thing that I had noticed after starting to work with homeless veterans is I was really struck by, we think a lot of times with veterans, obviously military trauma comes to mind, but oftentimes most homeless veterans have experienced trauma outside of military service, and multiple traumas, and sometimes in addition to military service. So it's a compounding effect of lifelong traumas that a lot of them have had, that I think is important to keep in mind. So next slide. And in terms of health consequences of trauma, trauma exposure can have a lot of different consequences, and it's very individually specific. I think the main point of this slide is to just highlight that PTSD is one consequence of trauma. People can have develop depression after trauma, other anxiety disorders. Pretty much any disorder can be generated or intensified by a traumatic experience. And as you can see at the bottom, there is a whole slew of different symptoms that can arise in result of trauma. So I think it's important to broaden our view of like what possible consequences of trauma are, which may be related to how we assess for it in these types of settings with homeless veterans. Next slide. In addition to the health consequences, trauma exposure definitely also impacts service use, and can lead to different barriers to care. In general, just working with trauma survivors, regardless of whether they're veterans or homeless experienced. Oh, I just did something to my screen that zoomed in. Okay, there we go. Sorry. Um, they tend to if they're offered referrals, they often decline or they'll accept it but not show up for appointments. This goes hand in hand, and it's important to recognize this is not resisting care, but more of a response to the trauma, because avoidance is a huge part of the trauma response. It's very painful to relive trauma and to think about it. And that is, in the end, though, the same thing that kind of maintains the trauma's impact on a person. So it can be difficult to work with at times, but um, I think it's important to come with understanding that this can be happening, and it can essentially be understood as one of the consequences of trauma and something that's maintaining the problems that they're having is the avoidance and just wanting it to go away, not wanting to forget about it. Um, Also, veterans oftentimes may not realize the connections that may happen between homelessness, trauma, and PTSD. One of these things is when people hear the word trauma, they often think about like military trauma. But as Jay mentioned, it often it co-occurs with becoming homeless, experiences that people have when they're homeless, childhood experiences like ACEs, adverse childhood experiences, um, and just like domestic and interpersonal violence that they experience that happen outside of military as well. And just other examples of like wanting to maybe avoid this would be the emotional pain. Um, sometimes veterans hold beliefs that talking about it will make it worse, even though in opposition to that, actually addressing and processing the trauma is something that can make it better in the proper circumstances. Um, or they um, uh, or they may hold beliefs that um, like they don't trust the system or they don't trust providers and things like that. When people have a lot of trauma, that can sometimes come up um, in terms of their like healthcare exchanges and other service use. Next slide. So then moving on to what does it mean to be trauma informed? And like I said, I'm going to be focusing a little bit on more of like the program organizational or system level of being trauma informed. Um, and so that means like the service providing care to the homeless veterans in general, like from a system level. It being trauma informed means that the program takes approaches that they realize the widespread impact of trauma. In fact, most people have experienced a trauma in their lives, whether or not that actually then leads to consequences that are lasting. That's a different thing. But trauma impacts of trauma are widespread, especially among homeless veterans. And a trauma informed program understands there's many different paths to recovery and um, also are informed about the signs and symptoms of trauma in clients and others involved in the system. They respond by fully integrating knowledge about trauma into policies and procedures and practices of the program, which I'll talk a little bit more about in a minute. And also importantly, they seek to actively resist re-traumatization, which is something that can happen when, like, for example, something in the environment of the service program could um, activate trauma reminders for a person it could even be things that aren't like directly linked to a trauma, but give them a feeling that remind them of the trauma, such as like maybe it was an interpersonal trauma and they don't that they felt violated or not taken advantage of and things like that. If some of those feelings come up in service situations, it could be bringing up some of their feelings about trauma. So that's why on on the next slide, I'm going to talk a little bit about some of the key principles um, that can help to reduce the chances of doing that. Um, but I think in general, the point I want to make is that when you have a trauma informed program, it can do a lot, not only to improve veteran like engagement with care and healthcare outcomes and their well-being. It can also trauma-informed care programs can also improve and support well-being of the providers and of that are supporting the veterans in the program. So yeah, go ahead. You can switch it now. Thanks. So this is the list of some of the key practices of trauma-informed care principles that I was mentioning um, is about um, prioritizing safety, like making it a safe environment, trustworthiness and transparency, um, like which is kind of letting the veteran or patient know about all the expectations, what would happen in treatment, so they aren't surprised by things or caught off guard or um, feel like you didn't communicate or be totally honest with them. Peer support is also a huge part, so it's not just about licensed providers, people who have gone to school for being a provider. It's also about um, having input from the people with lived experiences and having their support and helping the patients. Collaboration and mutuality is very important. This kind of goes along with like having a collaborative or shared decision making kind of like interactions with veterans in terms of their care, meeting them where they are, not telling them what to do. Um, Empowerment, voice, and choice are speaking to emphasizing very strengths based approaches as opposed to focusing on symptoms, focusing on what you can build up in strengths to help them help themselves, and also giving them the choice of about their care and things like that, making them feel empowered. And then lastly, also uh, attending and considering all the different types of cultural, historical, and or gender issues that might be coming up that could um, that could also interact with people's trauma and their long-term consequences, as well as how those impact their interactions with the care system. So I think the main point now that to realize as we start to talk more about systems trauma informed care is that when you're talking about trauma informed care at the organizational level, it's very much like a transformation or cultural change of the system. So while people can be provide trauma informed care on an individual basis, of course, for the full program to be trauma informed, it really is a full system organizational change that I'm going to be talking about a little bit more. And that organizational change can in turn better support providers with adopting trauma informed clinical practices. Okay, next slide. So this is a very wordy slide, but it gives like a comparison of examples of what it would mean for of examples of what trauma informed system and later mindsets are, and what on the left what would be the opposite or what they aren't. And so, kind of in line with all of the principles that I was just talking about. Um, and the importance of a system level change, which kind of starts with leaders um, and their leadership of the program. Um, the principles that are trauma informed are being curious, coming from a point of curiosity rather than being judgmental, like sharing and having power with instead of having a power imbalance, and um, having like a hierarchy where providers are the experts over patients. That would be not trauma informed. Um, relational exchanges where you're focused on building the relationship and instead of more of a transactional change or transactional exchange. Being trauma formed is also um, being reflective, believing in collective expertise. So really meeting, this kind of goes along with meeting the veteran where they're at and listening um, to what they want, and being collaborative in that interaction. Also being flexible, um, and along with kind of meeting the veteran where they're at and integrating with other services. There's so many different services that homeless veterans interact with, and care can sometimes be disjointed. And when there's efforts made to have more integrated care or even better transitions between care for the veterans experience, that can make a huge difference. All right, next slide. This is a list of just some trauma informed care practices that are examples of ways that um, organizations can promote trust and supportive relationships among leadership, staff, and patients alike, the whole service system and who interacts with it. Um, Obviously, utilizing a relationship centered approach consistent with what I was just talking about among the leadership and staff, that fosters partnership and collaboration is really helpful for setting like the system level environment that is also collaborative and working with patients and feeling like everyone is heard and their views are valued and things. Providing standards for engaging veterans based on trauma informed principles, making it a priority to talk about the importance of um, taking that into account, and maybe practicing or talking about ways to do that can really support providers, especially those who are so time burdened and seeing many veterans, um, many of which might have trauma. So establishing and maintaining a process for monitoring quality of engagement and collaboration with veterans across programs. So this kind of speaks to the integration and transitions between programs, making that a priority to ensure good care throughout the system. Establishing and maintaining a process for identifying and addressing issues of disproportionality and disparity. This, which goes hand in hand with making sure that all people's views are valued. Everyone is part of the conversation and is important um, to in the collaborative care environment. Um, Maintains commitment to peer-led programming, um, as peers are very important for understanding lived experiences and have valuable input on that, and can really help veterans understand veterans uh, care and maintaining engagement with care. And again, kind of in the same vein, culturally responsive. Um, So this is the example that I wanted to highlight that's been going on. I think for now it's been about a decade from the start. Um, the VA's National Center for Homelessness Among Veterans, specifically providers in the homeless program office or associated with homeless program office at Boston VA started this initiative, like I said, about a decade ago. That was at that time mostly focused on some assessment and training initiatives because they felt the need for improving competency on trauma informed care, and also wanted to take an assessment of how it's being used in homeless programs in VA. And so this was a small group of providers that were specifically working with very high need homeless veterans. So, as an example, in addition to being hard to house veterans, they were veterans with the average was over 10 ED visits in a 6-month period. So it was very high utilizers of care too. Um, and so this went on for a couple years. In 2021, they put together all the results they got from their assessments of programs, which were really focused on the questions of, are we using trauma-informed care approach in homeless programs? If so, what does it mean? And what difference does it make? If not, what should we be doing, and what should, if not, should we be doing something, and what should we be doing? So really trying to understand people's views on this in the field that we're working in the homeless programs. Next. Um, I think one of the big findings that they've mentioned in the report too is that there was a lot of differences in what people thought trauma informed care was, and there was very much a differences across programs and how much people felt supported in using those types of principles in care with veterans. But moving back to the Boston VA program that I was mentioning, the group of providers that kind of initiated this, um, they started a program called Catch, Care Coordination, Advocacy, Treatment, and Connections program, and as well as a trauma informed care integration initiative in the homeless programs. So it's kind of like two linked programs that were developed by them. I can't take any credit for any of this, but I think it's a great program. I've talked to them about it before and heard the great work they're doing. Since 2023, there's been work to replicate that program in 2 other VAs. So it's starting to be disseminated elsewhere. And as of little over a year after that, across those 3 programs now, which remember, this is a hard to house, very high need homeless veteran population. Over half of the veterans in that program had been temporarily or permanently housed. So now I'm going to talk a little bit, next slide, I'm going to talk a little bit more about how the program structure and also like how the implementation happened. So this is the mission and values for Catch. Their mission is to improve the quality of life for high-risk veterans experiencing homelessness through access to housing and care that is veteran-centered, collaborative, and trauma-informed. They values are veteran-centered care, respect, safety, transparency, partnerships, peer support, and advocacy, which sounds very similar to a lot of the principles of TIC that we were just mentioning. Next slide. So this is just a picture to kind of show that how it fits with the other. If you're for someone that's familiar with um, the VA homeless programs, on the right side you can see the programs that you might be more familiar with, like HUD-VASH and Healthcare for Homeless Veterans, Veteran Justice Program, and Grants and Per Diem Program. Which Grants and Per Diem is the program that kind of funds the community-based homeless veteran programs. And Catch is kind of brought on as another program that was specifically focused on these high need veterans when it seemed the veteran was a fit for that. And the Catch teams include veterans who are supported by like a supervising social worker for the team, another social worker, and a peer specialist. So it's almost like a care team that the veteran is supported by. Next slide. These are some of the things that they did to support the implementation, or I guess replication, at the 2 additional sites in recent years. So because the Catch program is a little bit associated with healthcare for homeless veterans, like outreach programs for high need veterans, they the kind of setup of it was very focused on the education and outreach for homeless and VAMC staff, and creating notes for the people who would be working in this program, like the CPRS is the VA's electronic health record, and helping them identify prospective veteran participants, because it's a very specific, it's a small program at this point, so it's very focused on the very most high need veterans. And then of course the initiators, the Boston VA Catch team, provided training and mentoring through all these different in all these different ways, connecting the new programs with partners, helping them like consults for identifying consults and tracking them, because this is a hard population to track, and all the and kind of moving through the consults to pick the veterans that are most relevant, or referrals elsewhere, caseload management and tracking, peer support. There's also like weekly office hours and monthly trainings that they provide. And in addition to the support from Boston Catch team, these new sites also got additional trauma-informed care training from the American Institutes for Research, which was the foundation or organization that consulted with the Boston Catch team when they were initiating this program and conducting the large-scale assessment they did originally. You can move on. And I know I'm short on time. I'm almost done. So this is just showing then more going into how the trauma-informed care integration works. So in terms of like the steps to integrating it within a program or organization. So starts with like kind of like understanding needs, assessing the environment of care, and then sharing results and action planning for these to make organizational change, and then having ongoing training, and then like a community of practice set up for the Catch program. Next slide. I think it's my last. Yeah. And this is just the example of an assessment that's been used in this process that really focuses on organizational capacity and interest in trauma-informed care, not just like an individual person in the organization. It's focused on the organization. And it evaluates efforts to build trauma-informed knowledge and skills, the trusting relationships, respect for service users, of course, trauma-informed service delivery, and promoting trauma-informed and organizational promotion of trauma-informed procedures and policies, like how much support there is from the organization for providers to be implementing these things. So that has also been fundamental to the process of implementing in the program. I think that's my last slide. So thank you very much.
Thank you so much, Dr. Messia. All right, we're going to move on now. Jenny, you have the floor.
Hey everyone. We have had some technical difficulties this morning, so if you will just be patient with me here. 1 second. Let me get out of this here. All right, so my name is Jenny. I'm really excited to be here with you guys today. And we have been we have been just so excited to have this conversation. Mine is going to be a little bit more general, actually, because Dr. Catherine just did a great job giving you some really specific examples. If you can go to the next slide, I just want to introduce you really quickly first to Easter Seals Mork, who we are, what we do. And we are a nonprofit serving Michigan. Easter Seals, as an organization, is all over the country. In my state specifically, we've joined with an organization called MORC, and we work now with the entire lifespan, from prenatal all the way through geriatrics. We work with behavioral health. We work with IDD services, substance use, kind of the whole gamut. And we are over 1,000 people now working with our communities, and actually over 1,100. Sorry, that's changed recently. And we serve around 20,000 children, adults, and seniors consistently, which is such a big feat, and really proud to be a part of this place. We are a certified community behavioral health, and we have many outpatient sites throughout the lower part of Michigan. If you're familiar with Michigan at all, there's the part that looks like a hand, and then there's the top piece. And we are mostly in the part that looks like a hand. And we have many sites throughout the lower peninsula, and we're also co-located with about 15, I think, school districts throughout the state. If you want to go to the next slide, which is really exciting, gives us an opportunity to really get where the people are, get where the kids are, and help them in really real and tangible ways. Before I get going too much, I again, mine's going to be a little more general. Wanted to give us some not technology, guys. Technology's on the brain today. It has not been my friend, but terminology that we can all use as we're having this conversation. These first couple slides are just going to be kind of getting us all on the same page as far as that goes. And so these first couple of terms, I know you guys have probably heard before, you use maybe even pretty frequently, but again, just to kind of get us all on the same page, we wanted to touch base here. The first two are compassion fatigue and secondary traumatic stress. Compassion fatigue is kind of an interesting one. I'm going to introduce you to something toward the end of my presentation from Dr. Brian Miller, and he has some kind of different thoughts about compassion fatigue. But I think a lot of times that phrasing gets a little bit confusing for us. It's not really our, and so we always just want to be clear, it's not really our compassion that is fatiguing us, it's our compassion that is fatigued by the work that we do, by the systems that we encounter, by the red tape that we face like consistently in doing this work. And so so that's one thing we always just like to clarify with compassion fatigue. Secondary traumatic stress, again, I'm sure you guys have encountered this phrase before and have used it, I'm sure, in describing some of your feelings before. But this is basically just the stress that we feel and that we carry working with those who have experienced traumatic stress. And you know, in a group like this, I don't have to say we all work with people with traumatic stress, but I'm going to, because I think the other thing that is important for us to remember is that even if we're like you guys are working a lot with like veterans and people who have served our country, and there is a lot of really obvious trauma in that. Also, as you work with your coworkers, you are working with people who have experienced traumatic stress. Everyone has experienced some kind of trauma. That is part of trauma-informed care, as she said earlier, that we kind of have this assumption that trauma is everywhere and is a part of all of the pieces. Let me see something here really quick. All right, and you can go to the next slide. The next two here are going to be burnout and vicarious trauma. And vicarious trauma is part of trauma, secondary traumatic stress, but it looks a little bit like it goes a little bit further, where we start to carry the trauma as our own trauma. We start to convert what that person has experienced into our own experience, and we start to carry it as if it is our own. That obviously gets into a really serious level of traumatic stress, that if we're starting to hit that, we want to consider like, hey, maybe I need a break. Maybe I need to take a little bit of a step away from some of this, so that we can really kind of make that separation and take care of ourselves, so that we can better take care of the people we're working for. And then burnout. This is one that I think is one of those phrases that we use a lot in our society and our culture. I'm so burned out, I'm so tired, I'm so whatever. And I think that's, that's fine. We are breaking stigmas by using these things in language more consistently. However, what this one is talking about is a level to which at this point we need to step away really completely. This is I don't have anything left inside of me. I don't believe that what I am doing has any purpose, has any progress here. I don't see any way that this could work well at all. I see nothing that I have to give to anybody who I might work with. And so this is actually a really serious level of secondary trauma. And at this point, again, we want to just step away and take some time to heal ourselves, so that we have something and to give other people, and we have a belief that what we're bringing is good and is useful and helpful. So if you want to go to the next slide. um, All right. So the other terminology here that we're going to just be really clear about amongst ourselves today is resilience. Again, I'm sure you guys hear this word all the time. I know this is kind of becoming a word people are tired of hearing, almost as much as they're tired of hearing about trauma. But for our purposes today, we're just going to use this definition of the capacity to recover quickly from difficulty, or the kind of, just if you like just look up what is resilience, the answer you're going to find is the ability of a substance or an object to spring back into shape. It's elasticity. So when we're looking at the elasticity of how much do we have, that when we hit a setback, we can kind of bounce back with it, and make it something that we can come back to heal, and to kind of, if we hit a setback, we can feel that setback and keep moving forward. The thing about resilience, though, is we don't want to just like feel that setback and come right back to the same place. We're looking to feel that setback and move forward, even go a little bit further each time that we have a setback like that. And when we look at this, in my work specifically, the stuff that I've done historically, we look at it in kind of three main, I guess, pillars, you would call them. But it's mastery. Do I believe I can do the thing that I need to do? Flexible coping skills. Do I have the coping skills that I can address situations in various environments? And do we have supportive systems? Like, do I have people to walk with me in this, to help me in those moments where maybe I fall back and I'm struggling to get back up and get going? So, the example I always use, especially for flexible coping skills, is, I really love listening to Jane Austen on audiobooks, especially Pride and Prejudice. And so I will very often, like when I'm feeling stressed out, if I'm like at the store and it's just too overstimulating, over here living that ADHD life, and I can get really overstimulated. And so I'll put in my headphones and I'll start listening to Jane Austen, and I'll say it out loud. And it is a truth universally acknowledged that a single man in possession of a large fortune must be in want of a wife. However little known the feelings or views of such a man may be upon first entering the country. And I'll just start going. I'll start saying it out loud to kind of reset myself and re kind of center my own core to something that is familiar and something that's very grounding for me. But if I was to do that in like a meeting, if I was getting really stressed out or really overstimulated in a meeting, obviously that wouldn't work so well. My boss probably wouldn't appreciate that. And so to have flexible coping skills, we say we want to be able to have coping skills that I can use when I'm at the store and I'm overwhelmed, or when I'm in a meeting. What can I do to kind of calm myself down, to kind of continue functioning in that way? You can move to the next slide. And so those are the three pillars that we focus on, mainly for resilience, just as a real broad kind of thing. The other thing that I want to just talk about really quickly is low impact disclosure. And this is something that I wasn't sure if I was gonna try and talk about today, but I do think it's important because you guys are working with people who've experienced significant trauma, very intense trauma. And a lot of times when we get hit with the intensity of that, it can be a lot. And so we'll say to our coworker, hey, Stephanie, do you have a minute? Like, I need to talk. And we'll just go and we'll verbal vomit all this stuff. And there's been kind of a thought historically that that's cathartic, that that's going to help us, that that's going to make us like feel better, like we got it off of us. And boy, we feel so much better. And in one way, I get that because I'm an external processor. I need to kind of talk things out and do it that way. But also, that then puts it on Stephanie. Now, Stephanie is the one holding that, and she has to go and verbal vomit. Sorry, that's like the language I use. We also use slime. She's going to go and slime that on somebody else. And that ends up just kind of perpetuating something that is not great when it comes to how we work with each other. And so low impact disclosure asks us to be really self-aware of like, what is it that's really bothering me? What's the part I need to share? Giving fair warning when we're talking to other people, like, hey, I need to say something, are you prepared for that? That's the consent piece. And then giving that limited disclosure so that we're able to talk about what the piece is that's really bothering us without just placing it on another person and expecting them then to carry it themselves. Can you go to the next slide? So that was just something for us. Those are just some things for us to keep in mind as we talk about what we think of when we think of trauma-informed care. And so when we think about trauma-informed care, we're thinking, are we trauma aware? Are we trauma-informed? Are we trauma-specific? A lot of times when I'm talking to my organization and my teams about it, I'll say, we're working hard to be a trauma-informed organization. That's part of what we're doing here. And they'll say, well, I don't work with people. I don't work with trauma, so I don't need to worry about that. Oh, and nothing, nothing just makes me just pause for a second to do my own little breathing exercise, more than that sometimes. But that's talking trauma specific. So that's when we're talking something like in kids services, there's like TFCBT, trauma informed CBT. There's EMDR that people use a lot to address trauma. Those are trauma specific services. But we also have trauma aware and trauma informed. And trauma aware is just, hey, we know that it's there. We're kind of aware that it's out there and that it's a part of what we're doing. But trauma informed, as she talked about just a little while ago, is something much deeper, baked into the framework of what's happening and of who we are as an organization. It is something that we don't we don't practice anything that would re-traumatize. We're working really hard to practice empathy and create a feeling of safety for everyone who comes into our place. In trauma-informed care, we assume that everyone has experienced trauma, and so we create that system and that place of safety for everyone who comes in. If you want to go to the next slide, those are just kind of the three ways that we come at trauma. When we look at a trauma-informed organization, again, I'm going to try and go through this part very quickly. I know I talk fast. I'm so sorry, guys. I want to make sure we get to be able to answer some of your questions as well. But when we look at this is just a little circle I created when I was talking with some organizations about trauma-informed care. So we to give this idea that this is a cyclical thing. This is we never like hit it where we're like, man, now we're trauma-informed. We don't have to think about this anymore. This is going to be something we're constantly growing in and constantly affirming that we have a commitment to trauma-informed care. We're going to assess how we're doing with that. We're going to make a plan. We're going to implement that plan and we're going to follow up. And then we're going to recommit to the process. We're going to reassess, we're going to plan, implement, and follow up. And this is something that kind of like in resilience, we're hopefully not coming back to the same place every time, but each time we're getting a little bit further and a little bit further. And this is something that we just continue to work on as we move forward. If you can go to the next slide. So that's just something to kind of keep in mind through out this part. She already talked about this, so I'm not going to talk about this too much. But one thing I do want to point out, this is SAMHSA's 6 pillars. And I will say SAMHSA recently changed their pillars, and they only have 5 now. But this is a pretty infographic here, and I like this one. And I think it explains it really well. If you go and look up the 6 pillars of trauma informed care according to SAMHSA, you'll be able to find this and hopefully read that a little bit better. But the 6 she mentioned. But one of the things they did when this first came out is they had this kind of 7th unofficial pillar, which was the staff wellness and development piece. And we're going to talk about that in just a minute. But I want us to keep in mind these 6 things. And when we're talking about trauma informed care, one of the things that I do with my teams when I'm doing consulting with some of our counseling teams is, you know, a lot of times people get really overwhelmed. Like, I'm working with this person, we're dealing with this topic, I don't have time to think about, you know, X, Y, and Z, like all these 6 pillars, Jenny, I can't think about all these things and be present in the moment with the person. Okay, that's fine, I get it. So what I'll do is I'll say, hey, just tell me, how would you talk about this topic with somebody? And I ask them to kind of walk me through what they would say and what they would want to communicate, and how they would do it just naturally, completely disregarding, you know, trying to be aware of the 6 things. And a lot of times, guys, I know this list can be overwhelming to look at when you're in front of somebody, but a lot of times, because of how we're trained, these come out naturally. You're doing them already. This is just about creating intentionality and saying, like, hey, when I talk to this person, I think I hit this, this, and this. And maybe I can be more intentional next time I talk to them about hitting this and this. And allowing us to, it just gives us like a framework, so that as we're working with people, we have the chance to kind of think a little bit more about how we approach this, and are there areas that maybe we have a blind spot to. I think that's just important for us to continually ask ourselves when we're working with people. If you want to go to the next slide. I think this next one goes into, the 10 implementation domains. And again, she spoke a little bit about what it is as an organization to be trauma informed. Again, this list comes from SAMHSA of the 10 domains. Sorry. And one thing that's really important, I always want to just point out here is, yes, I can talk about what it is to be trauma informed with a client, and that's great. I think again, it fits into a lot of those 6 pillars, and how are we hitting those things? What do we need to be more intentional with? But I always, again, want to remind people, when I talk to people and they're like, hey, I don't work with people, I don't do the trauma care thing, so like, I don't need to worry about this. Everybody needs to worry about this. This is 10 domains of trauma-informed organization that needs to be addressed. How is HR addressing people when things come up, when there's a problem? Are they being trauma-informed? How is the finance department when they have to call and talk to somebody about a bill, or they have to call, you know, insurance, or they have to do something? How are they practicing that trauma-informed care, those 6 pillars? What does it look like for our screening for our intake departments to be trauma informed? What does it look like for our policies to be trauma informed? This is just stuff we want to think about. I'm going to keep moving because I think she did a great job talking about the organizational piece. If you want to go to the next slide. So yeah, even facilities, that's the other one on there. Even facilities, how are they kind of practicing that? Again, just making sure that this is something hardwired into our organizations, that it's not just that, hey, we did a training, we're good, we're trauma informed. That's a checkbox. That is not what we're talking about. We can have really well-intentioned leaders. I'm the trauma informed care consultant for Easter Seals Work. Everyone knows Jenny's the one who talks about trauma informed care. I love it. I love talking about trauma informed care, but it can't just be based off of one really good, well-intentioned leader in the organization. This really has to be something that's baked and hardwired into who we are as an organization, into how we interact with our people, and how every single person who interacts with our people interacts with our people. Go ahead and go to the next slide. I believe this is the one about CSERT from Dr. Brian Miller. If you guys are not familiar, yep, go ahead and go to the next slide. If you guys are not familiar with Dr. Brian Miller, I really recommend that you look him up. The book is, I think, called Reducing Secondary Traumatic Stress in the Helping Professions or something like that. If you look up that book, if you look up his name, you will find it. You know, there are lots of trauma specific modalities that you could use in working with people who've experienced trauma. But this is one of the most significant things I think I could tell you about ways to take care of yourself so that you can work with people who've experienced trauma. He has these 5 principles that he considers, and in each chapter about each of these ones, he has like 2 to 3 pages of ways to make it practical, ways to do this that you can do every day, so that you are not burning out. You are practicing that staff wellness so that you have the best you can offer to those who you work with every day, in the homeless population, in the veteran population. One of the things Dr. Miller says, I want to just say really quick too, is he talks about secondary traumatic stress, and he says that it's actually not about the intensity of the trauma that we face or the stress that we face. It's how helpless we feel in the face of that trauma, in the face of that stress. And I just think I think that is so brilliant, because if that's, again, it's hitting back to that resilience piece. If I know that I can do the thing I have to do, if I know that I have people who will stand with me when it gets hard, if I know that I have coping skills to take care of myself when it gets tricky, I know that I can face whatever I have to face with this client. And that's going to make me stronger. That's going to make me a more competent, trauma-informed care clinician. And so he goes through each of these 5. And again, he gives really good examples. He has like a couple pages talking about what it is. But then at the end of each chapter, he gives practical examples of how you can make this real in your own work and in your own life. And I just think it's such a good tool. I'm not selling it. I'm just a big fan, and I think it's really useful and helpful, and I hope it can be useful and helpful to you guys too. If you want to go to the next slide. This next slide is just a quote from one of my favorite trauma researchers. I'm a big dork. I'm a nerd. I will admit it. And I have a favorite trauma researcher, and it's Dr. Bruce Perry. He does a lot of neurological work around trauma. And he has this quote. He says, "Because humans are inescapably social beings, the worst catastrophes that can befall us inevitably involve relational loss. As a result, recovery from trauma and neglect is all about relationship, rebuilding trust, regaining confidence, returning to a sense of security, and reconnecting to love. And healing and recovery are impossible, even with the best medication and therapy in the world, without a lasting, caring connection to others." And one of the things that this points out to me, a lot of times I feel like people are like, I don't know the right therapy to do with this person. I'm not the person giving out the medicine to help this person. I can't be that significant to this person. Maybe I'm just the front desk person working with this person. Maybe I'm the facilities, maybe I'm finance, HR, whatever it is that whatever function we have in working with people. I always want to remind people in almost every thing that I do that healing and recovery are impossible, even with all of those great therapies and medicines in the world, without a lasting, caring connection for others. And you can go to the next slide. And I just want to say thank you to all of you who are those lasting connections for other people, that you have been that for everyone that you've encountered. And I appreciate that. And it means so much more than you could ever really know. I apologize for taking so long, but there we go. And thank you guys so much for joining us today.
Great. Thank you, Jenny. Thank you, Dr. Macia, for your wonderful presentations. I'm going to do like a quick rapid fire Q&A because I know we only have a couple of minutes here, but if you guys can stay just for a little bit longer, if you do have some questions that you do want to ask, don't mind. But so the first thing I want to ask is, so building trust is a really vital component to do this work successfully. What are some practical examples of provider interactions with veterans to keep them engaged in receiving services? Real quick answers to the both of you.
All right. I think that kind of starts with the shared decision making and collaborative approach that you would take with the veterans, and um, expectations up front about what treatment will involve, and also making sure you're always meeting them where they're at and what they're wanting out of therapy or whatever services.
Yeah, definitely, definitely. I agree with that. Making sure that they are centered in that, and again, that connection piece is huge. People will keep coming back. People will stay engaged with a really solid connection. Oh, you're muted, Jay.
Rookie mistake. So, what do organizations and individuals often get wrong about trauma, and how can we identify our own biases and improve that system of care and services for veterans? Just a few things that folks get wrong about trauma.
I think one of the main things that people get wrong about trauma a lot of times is that it's like a one-time thing, and you dealt with it and now you're good. It is something that gets baked into part of who we are, and it is something that our body responds to, and our body starts to shift how we interact with everything in the world. And so again, I just think we have to kind of look at it as an overarching thing, and really be ready to address all the aspects of trauma that we encounter when we work with people.
Dr. Macia?
Yeah, definitely agree with all of that. And maybe one thing is maybe not always realizing where trauma is kind of always showing up in the room with people, and keeping that in mind, and what might be going on with that is, I think, important. That sometimes can get in the way of successful work with patients.
Thank you. And one last question, and then I'll let everyone go. So, for the two of you, what lessons have you learned in your time with working with trauma clients, about working with this population? I'll let either one of you go first. Flip a coin. Lessons learned.
I think one of the main lessons that I've learned is just how incredibly strong people are. I never am. Um, I never hit the threshold of being like, I'm always constantly amazed. Every child that I encounter, every family that I encounter, to realize like what they've walked through and what they are still standing up to, and what they are still like fighting against in their own life and in their own self is really just so powerful to me, and is constantly inspiring to me as a clinician.
Thank you, Jenny.
Thanks. I think two things. One part is one thing that Jenny was speaking a lot about the taking, which I think of as like taking care of yourself and making sure that you're being resilient to be able to continue to meet patient or the veterans care needs, because and that's something that takes time to kind of develop and know yourself and what you need, and to make sure you make time to not focus on that, so you can be fully present when you're in a room, when you're with the veteran that needs care. And then the other part, I think, is also everyone's responses and reactions to trauma are unique, and the importance of really just meeting people where they are as opposed to being the expert in the room is so important.
Well, first, I want to thank both of our panelists, Jenny and Dr. Macia, for sharing such critical insights today. We learned so much about the fundamentals of trauma and what we can do to improve to improve our outcomes when serving those veterans who have trauma. But something that I think is really underscored in this webinar is how heavy this work can be for the staff in our organizations. And if we want to improve the efficacy of our existing programs, we need to know how to navigate trauma. But that being said, again, thank you so much to our speakers, our attendees, and the generous support of the Home Depot Foundation. So that wraps up our trauma-informed webinar. Again, we'll upload the video onto YouTube, as well as send the recording and the slides onto the email that you registered with. The next time you'll see us is on July 22nd. We'll be hosting a webinar at the same time as today on serving hard to reach veterans. So until then, I'll see you guys then. Thank you.
Thank you.